2 cases of diaphragmatic endometriosis. Diaphragmatic endometriosis is a condition that is part of the thoracic endometriosis syndrome, which is endometriosis of the diaphragm, pleural space, and lung parenchyma. Symptoms include catamenial pain, pneumothorax, hemothorax, pleural effusions, hemoptysis, and pulmonary nodules. The mean age of incidence is 35 years, which is later than the incidence of pelvic endometriosis. Patients typically have pelvic pain prior to thoracic symptoms, and 50 to 84% of patients with diaphragmatic endometriosis also have pelvic endometriosis. History is important in establishing a diagnosis, and definitive diagnosis is by laparoscopy. Imaging is not always helpful. Diagnosis is often delayed even after laparoscopy because disease can be hidden by the liver. Medical therapy is first line for management, similar to pelvic endometriosis. If surgery is needed, a multidisciplinary team approach including radiology, anesthesiology, thoracic surgery, and gynecology is important. Surgical procedures include video-assisted thoracoscopic surgery for thoracic lesions and laparoscopy for diaphragmatic lesions. Our first case is a 35-year-old gravida 2 para 2 with catamenial right upper quadrant pain. CT was unremarkable. She had prior surgery for congenital intestinal malrotation, and pathology confirmed endometriosis at the time. She also had evidence of central sensitization and had failed multiple attempts with medical therapies. She was diagnosed with likely diaphragmatic endometriosis and was consented for total laparoscopic hysterectomy, excision of endometriosis, and possible excision of diaphragmatic endometriosis. She also saw thoracic surgery who recommended concurrent possible video-assisted thoracoscopic surgery. Initial survey of the abdomen did not reveal any endometriosis until the liver was retracted. Adhesions between the diaphragm and the liver can be seen here and were taken down with the monopolar hook cautery. The diaphragm was then scored circumferentially around the lesion. Traction was applied to the lesion, and the striated muscle of the diaphragm could be seen underneath, as shown here. This endometriosis lesion was deep infiltrating and required full-thickness resection of the diaphragm. Here, you can see the window created into the pleural cavity, and the lower right lobe of the lung could be seen through this window. The endometriosis was completely resected and removed, and a liver retractor was placed. The laparoscope advanced into the pleural cavity. There were no pleural endometriosis lesions seen as shown here. The diaphragm was then closed with 3 interrupted horizontal mattress sutures with O-ethibond sutures. Her post-operative recovery was unremarkable. She had a small apical pneumothorax that was managed conservatively without the need of a chest tube and was discharged on post-op day 2. Pathology results of the diaphragmatic nodules were negative for endometriosis. According to the ASHRE guideline, negative histology does not rule out endometriosis. A recent review article of diaphragmatic endometriosis used an inclusion criteria of direct inspection surgically, and cases were not excluded if histology was negative. Furthermore, there was a case report showing endometriosis which was negative with basic histology, but the sample was positive for estrogen and progesterone receptors with immunohistochemistry. Another study of 55 cases found that only 1 case of thoracic endometriosis was positive with basic histology, and 67.3% of the cases were only estrogen and progesterone positive with immunohistochemistry. Therefore, negative pathology does not rule out endometriosis. She was seen in follow-up at 6 weeks and at 11 weeks and had ongoing right upper quadrant pain. She was re-referred to thoracic surgery for assessment and started on hormonal therapy. Our second case is a 44-year-old with long-standing history of endometriosis and chronic pelvic pain. She had a remote history of laparoscopic myomectomy for fertility and was noted to have superficial endometriosis at that time, which were removed. She was taking cyclic oral contraceptives and had right upper quadrant pain on history that was not responsive to medical management. She did not have any imaging of her chest. A nodule was seen in the right hemidiaphragm. Monopolar hook cautery was used to score the peritoneum circumferentially around the lesion. Chocolate cyst-like fluid was seen. Traction was applied and cautery was used to undermine the lesion. Ligature was used to bluntly separate the nodule from the muscle of the diaphragm and identify the dissection plane. Tissue pillars were taken down with the ligature. Care was taken to not enter the pleural cavity. The endometriosis lesion was completely excised without entry into the pleural cavity. The diaphragm nodule was positive for endometriosis. She had an unremarkable recovery, was discharged on post-op day 1, and had resolution of pain at the 6-week follow-up. In conclusion, diaphragmatic endometriosis may be difficult to diagnose. Imaging may be negative and lesions may be obscured by the liver surgically. Use of a 30-degree laparoscope and reverse Trendelenburg and a liver retractor can help identify lesions. Multidisciplinary approach in the OR is important if diaphragmatic endometriosis is suspected.